Okay. Good afternoon. For those online, sorry for the inconvenience, but we're having difficulty transmitting the lecture online. We just resolved that, so we will go all over again for you to hear whatever we have discussed so far. And then for those who are probably signed up, if you get it, you can listen to the recording. I hope. Aisha, can you hear me?
I can hear you.
Okay, good. Thank you. Let me try and fix. Okay, that's excellent. So today Dr. Kozinetz is away, and I'm standing in for Dr. Kozinetz. My name is Daniel. I'm a doctoral student in epidemiology. Today we'll be discussing about natural history of disease. We will talk about prognosis, and then we will talk about ways of measuring this prognosis. This is chapter 6 of your reading your textbook. And then again, we sent out an article that was to be read by everyone. In the course of the lecture, we will try and discuss that article when we have become familiar with whatever we have discussed today. So let's briefly look at the objectives for the lecture today. Today we want to understand and be able to appreciate the importance of natural history of disease. And then we also want to be able to know some ways of, talking about the natural history of disease. So at the end, we expect that we will be able to evaluate prognosis through the use of measures like Case-Fatality Rate, the 5-year survival rate. We will talk about the observed survival rate, which is the life tables and the Kaplan-Meier. Then we will look at the median survival rate, and then we talk about relative survival rate. The natural history of disease. In your text, you could see the definition. In fact, it's the natural course of a disease from onset to the time of resolution. So we just want to see when a disease happens, it's initiated, and then it travels, and then at the end of it, what happens. So when we look at disease, we are thinking about what is expected out of the disease if there's no intervention. If no one is treated for getting some kind of infection. If maybe some infection you are not treated, or you get a particular condition and you are not treated, what will be the outcome? So first, why is it important for us to know the natural history of disease? Or why do we even try to describe and measure the natural history of disease? We said that it is important for us to know the severity of disease, so that we decide which clinical services and public health programs are important. So when we know that if a disease is not treated, this is the outcome. And when we treat the disease, we can compare the outcome of those treated to what would have been expected. And we know that, okay, this public health program is actually important, or it's effective. Therefore, we need to invest energy and resources in it in order to reduce the unwanted consequences associated with the disease. Of course, patients, which one way or the other, we're talking about when we have a condition, we would like to know what will happen to us. But sometimes we feel so scared, and the uncertainty can create a lot of stress for us. But when we know what is going to happen, or what we are supposed to expect, then we can know how to live our lives and how to even manage the condition. Then, when we know the natural history of the disease, it's also important because we have the baseline, and then we can compare that one to the treatment, as I earlier said. To measure the natural history of disease, it is important for us to know certain stages that are involved. And the first one is what we call a the point A. The point A is the onset of the disease. So when the pathogen enters your body and then something is initiated, there will be some kind of cellular changes which it may not be able to measure or we may not be able to detect, or we do not have that kind of technology to detect. So even in chronic diseases like hypertension or diabetes, it takes several years. So there could be some kind of changes in your blood vessels. When there's this development of this arteriosclerosis, it takes several years that probably we may not be able to detect. Then, after this point, as it progresses, we get to the point P, where there's obvious pathologic changes. And this is a stage where we have a very good resource and we seek some kind of attention. The changes might be able to, we might be able to detect the changes in the body. So the cellular change that probably has occurred because there's some kind of carcinogen or cancer-causing agent has entered your body and you have maybe mutations in your DNA, it might not be able to be detected early on, but as it progresses, when you start having abnormal cell formation and when there's that kind of tumor development, we may be able to see it at the early stage. If that stage goes unidentified, then you start developing obvious signs and symptoms. So that is the stage, the point S, where the signs and symptoms. And these signs and symptoms will drive the patient to seek medical attention, which is the point M. And when medical attention is sought, there might be diagnosis. So if we do some tests, we run a test on you, on the patient, you probably see that the person has got abnormal blood pressure or abnormal blood glucose level. And therefore, the person is diagnosed with diabetes. Or we run maybe another test to detect the presence of disease-causing microorganisms. And then based on that, we can say that you've got this kind of disease. Then when we have been able to diagnose, there will be some kind of treatment for you. After the treatment, then we expect some level of outcome. Either you get cured, the disease may not be curable, so you control it. Like you try to stabilize your blood pressure or glucose level, or you try to reduce the pains caused by arthritis. Or it may end with disability. So there's some kind of infections that can cause serious disabilities, like root ulcer, which are endemic in some developing world. I think most people may not be aware of it. Or you may have any other kind of disease that also brings you some kind of disability. For instance, if you have hypertension that is not uncontrolled, unfortunately, we may suffer from stroke that may not be curable. Then the inevitable may also set in, which is death. So when I get Ebola, the probability of dying is about 50%. Especially if you don't get treatment, then the probability increases. So it's unfortunate. But that is how disease will progress. And for some people, this second dose. So we got to this one. This is a very nice diagram showing all the stages I've spoken about. Then I asked a question about which stage do we think screening may be very useful? And that's the pathologic evidence, the point P, where there's evidence of pathology or evidence of changes, abnormal changes in the body. Yes.
So if, for example, you test positive for a genetic mutation, like in your genes, but your body has not started to make abnormal cells, would that be A or P? Stage A or P?
Well, genetic mutation, it's not every genetic mutation that will come with obvious disease. There might be genetic mutation that is normal. So we can't say maybe it's a progress, it's going to progress to obvious disease. But if you have a mutation in cancer, especially with they call it P50, I think P53, yeah, which controls the abnormal group. If there's a mutation, maybe you probably may not be able to see it at the early stage, but you only see the evidence of mutation when there's uncontrolled group of cells. So that's why usually people will see small lump, because the cells are actually growing within that area, and then they form a lump. So that is why maybe if you do what kind of screening, you might be able to detect that. At 8.P, I doubt if there's any technology for us to detect when there's a mutation in P53. There might not be any technology to detect it for now. Maybe there is, but I have no idea. I hope I've answered you.
Yes.
Yeah. Well, yeah. So that's it. So the genetic mutation is not every one of them that is bad, but some may be very deadly. Okay, so somebody wants to ask a question. Now, yes. We get to survival time, which is a very important measure that we use to check how long a person has been able to survive a particular condition. So it is an important measure of natural history of disease. And then usually it would have been better for us to know the survival time from the time of onset, the time of biologic changes, till the outcome of the disease is observed. So it would have been better if we can measure from point A till the point T, or to the outcome. However, it is usually we don't know the time of onset. It's so difficult for you to know when the person got the plasmodium or the Ebola virus into his or her system. This is very difficult to detect. So, if we want to do it from the time at which symptoms are observed, what do you think might be the problem with it? If we want to look at survival time, so let's say we are interested in when a person gets a disease, so the person dies. We want to see that if somebody gets disease A, how long will the person live until the person dies? It's an obvious difficult, but the best practice or the best measure would have been the day that the disease started, so the day that you die or you get cured from the disease. It is easy for us to talk about the day that we entered ETSU and the day we complete, because we know it. But usually it's difficult for us to know the day that the disease started, so we cannot use that. Then we may be talking about using symptoms, signs and symptoms. So the day that the first signs or the signs and symptoms of the disease start, so the day the person gets cured, disability or death. So, but we say, what would be the issue when we use the signs and symptoms as the start for counting the survival time? Yeah, she said it varies. What way?
Because some people they might not come until the symptoms are specific point at that point, or there might be variation.
Yeah. So our reaction to even the signs and symptoms will vary differently. Because somebody might have headache for the first time and report to the health clinic. Another person probably has been having repeated headache. So maybe your first headache associated with disease, you might not even know which one. So it may vary. So it becomes difficult for us to use the signs and symptoms. Then, so another issue is that if we use, let's say, the time of diagnosis for it, let me hide this because that's it. So often the duration of survival is started from the point of diagnosis. So, however, there's a problem with that. If we want to use the time of diagnosis, and then one major problem is, patients vary in the time, like the time they seek healthcare. Some people may not even go at all unless you get to a point where we call ambulance for them. Yeah, so at that time they have no, they cannot say whether they will go or not because. So that's one thing. That's one difficulty. Some people may not seek attention at all. Others too may seek attention for minor symptoms. So that's going to be a problem. And then another issue with using diagnosis is that what about people that will even die before they are diagnosed? So there are people that will die at home. Maybe in countries like in the United States or countries that have high resources and will perform autopsy to detect the cause of death. Okay. But in some countries where you die and the next evening you are buried, yeah. So you might not be able to detect the cause. In some cases, even if they preserve the body, they preserve it in a rural area somewhere, the death is not reported and the person is buried. So you wouldn't know the actual cause. So the counting would be a problem because you'll be selecting people who go to the hospital, who have the resources to pay and who get diagnosed. So, and some diseases such as arthritis, they start and develop so slowly that it becomes difficult. And when you ask the patient, what time did you see the symptoms, it's quite difficult for them to know. And they may not give you accurate information. Because, for instance, personally, when I stand, maybe I have some pains in my leg. Well, I don't believe it's an arthritis. It might be arthritis, but after several years, I don't think I'm going to count down as arthritis maybe because I'm tired. Or you know it is. So that's one issue with using, deciding on which point you should start counting survivor. So what do we do? There's no point counting survivor or what? That's the question. In epidemiology or most of the sciences or even everything, there's some kind of caveat. So you have to know the setbacks of every measure that you're using. But these setbacks do not make the measure useless. So also, when survival is counted from time of diagnosis, patients who die, I think I said this. And when this happens, it will lead to underestimation of the disease. And this is an issue for me. It's a good learning experience. Okay. I hope you can see. Practice and move on. Okay, so let's make use of it like that. At least you are sure next week it will not happen. Now, so if we use diagnosis as a starting point for measuring time, it is important to also know how the diagnosis was made. So there's not always a clear diagnostic text available. You might have you have a problem, you go to this medical doctor, he will tell you this is it. Go to another, especially when it has got to do with reading text, maybe reading image to detect whether something has developed. Somebody may interpret it as having obvious problem. Others will say, no, I think this is normal. So the opinion about the test may also differ. So that in one hospital, you see, if you see this, it shows that the person has started developing colon, maybe cancer or something. But in another case, it may not be the case. So there's some disease also, like some disease diagnosis based on tissue biopsy, but interpretation of these biopsy slides may vary. So opinion about this may vary. And then some diseases such as headaches or lower back pain are based on subjective evidence. So if a pain is what the experienced person says it is, so somebody says I have pain, you can't objectively say you have or you don't have pain. That's it. So you have to consider this issue when there's any survival duration. Now, we can also measure prognosis, either in terms of death or in terms of survival with the disease. So then the endpoint is there, but of course, we are interested in the interval until the death occurs, because death is actually inevitable. Everyone will die. I don't know whether there's someone in this room who will not die, but if observation is true, what we have observed is that nobody has survived over 200 years. We've not seen anyone yet. Maybe in the past, but no now. So death is inevitable. Even if you survive over 200 years, we know one day you will go. So there are other important endpoints which we use as intervals from diagnosis to reoccurrence of the disease. So in some diseases that will relapse, like mental illnesses, some mental illnesses, that kind of relapse. In those diseases, we can use the survival as the time to reoccurrence of the disease or to relapse. And then we can use the time of disability. We can also use changes in quality of life, but that we will not discuss. And because the quality of life is a whole issue on itself, but people survive conditions, and as we sit here in this room, the quality of life of everyone will differ. If we give a scale to rank how happy we are with our lives and all those things, you may see so many things that are horrible, and other things that are so good that people are so extremely happy with their lives, others who don't wish to be. Now let's look at case fatality, which will be a measure that you will probably hear a lot. It is, I think last week you discussed case fatality, so we'll talk deeper about it. So the definition is that given a person has a disease, what's the probability the person will die from the disease? So if you get a disease, what is the probability that you're going to die from the disease? Now, a case fatality will differ from mortality rate because of the denominator. In case fatality, we are talking about the denominator being the number of people who have the disease, and then the numerator, how many people died. And then the mortality rate, we are talking about people who died as the numerator, but the down is the entire population at risk of having the disease or dying from the disease. So it will include both the people who have the disease and those who don't have as the denominator. So everyone who is at risk of dying from the disease. So you're at risk of having the disease and dying from the disease. So that's the difference between the case fatality rate and the mortality rate. Now, usually when we hear case fatality rate, the implication is that actually mortality occurs within a short period of time. So death from the disease has a very short duration, and that is the implied thing. It could mean something beyond that. But as we discussed, you know why usually they want to use case fatality to measure a disease that has a very short course. Either you die within a short period or you survive it. That's it. So it refers to the immediate and relatively short time period after diagnosis, during which death might be expected to occur. And then it is a best measure for disease that has a short course, because if the disease has a very long course, then other computing risk, because there are so many things that of course if you survive from one other, then you increase the risk of dying from the other. So if somebody has hypertension and you want to measure case-fatality rate, it may not be accurate because it has a long duration. People might die from other causes aside from the hypertension. But if the person has Ebola, you know that within 1 or 3 weeks, actually he is dying from the Ebola and not. He could die from maybe road traffic injury, which may be, but counting in that instance is more accurate than. So another useful measure of prognosis or natural history disease is the 13 years. And another term for that 13 years is the incident density. So the 13 years actually measures the years at risk of dying. So how many people died divided by the number of years that people were at risk of dying. So, an example that I was giving, if 2 people have a disease and each of them maybe live for, let's say, 5 years, then the number of years, the total number of years is 10 person years, because 2 people living for 5 years plus another 5 years. In the same case, if 10 people live for, if 5 people live 2 years, and the person years become 10 person years. Indeed, apart from the years, we can have person months, person weeks, or even person hours, if we wish to do that. So, when we use the person years, we are assuming that the risk is the same for every year. So the risk of dying is the same. But that may not be true. Because in some conditions, you have a greater risk of dying at the early onset, after which your risk of dying reduces. So when we look at our Gordis, the book, we could see some examples, but we have this thing here. So this is the scenario that we can use to illustrate the point that if we have a disease where there's a higher risk of dying within the first 2 years, and then we have 5 people live for 2 years, they have 10 person years. Then we have 2 people who live for 5 years each, they have 10 person years. You could see that the risk of dying, the number of years at very high rates of dying is higher among the 5 people, because the 2 people, after the first 2 years, their risk of dying reduces. But in this measure, we assume that the risk of dying is the same for each year. So that's the disadvantage with using the person year. So if you use the example, so the period of the greater risk, and then the rest of the period not at risk at all. So we have to recognize that the unequal risk of death for the different combinations of these person years is possible. However, it is still used as a denominator for most of these calculations. Because, of course, it is believed that we take into consideration all the time. And usually when you have a very large population and you want to reduce the number of people, it becomes difficult because when populations are not stable, people move in and move out. See the point? So if you have a study and you're observing people, the people that will come into the study will move out. So how did you account for this? But if you're using person years, you can, if I I'm in a study for 2 years, can calculate my time, add it to other people, even though I've moved out. But you know that you observed me for 2 years, so you have 2 person years. You can add it, and then you get somehow accurate measure of the period at which that you've measured people. So that brings us to the 5-year survival rate. So this is another measure that we use to express prognosis. Usually, you will see this 5-year survival rate in cancer. As soon as you type 5-year survival rate in maybe Google Scholar or PubMed or something, you see cancer popping up because it has been used. So is the percentage of patients who are alive 5 years after the treatment begins or 5 years after diagnosis. So why do we use 5 years? That's the question we usually want to ask. Why do we not use 8 years or 6 years or 7 years or 10 years? But actually, the article that I sent out, they use 10 years survival rate. It is ready. But of course, the 5 years or the 5 year was used because it has been observed that most cancer deaths occur within 5 years. So if somebody would die from cancer, then usually the death will occur within 5 years. Most majority. So that's why they use the 5 year survival rate. Now, problem with the 5 years survival rate, especially when we use screening. Because when we use screening, we want to make sure that our screening is helping to save lives. How do we do that? We want to say that also screen people, we've seen the disease at early onset, and we've been able to treat the person. And therefore, we expect that people who have been screened, treated early, will have lower mortality rate compared to those who have not been screened and treated early. So they use that to measure. But when they do that, they have what we call the lead time bias, which is associated with 5 years survival rate. Now, when we detect the disease early, and then we treat, you see, we have actually lengthened the time of survival just by having the disease early, and not just by prolonging the time the person takes to die. So it's like same things that we spoke about, that people seek medical care differently. So here, what we have done is that we've gone for people and we've tried to diagnose them early so that we treat them. And then, so what we have done is to go back in time. So by doing so, even if they die after 2 years, all that we have done is we have helped to detect the disease. So maybe the treatment does not improve, does not prolong the life of the person. While the person that maybe got diagnosed and then died within 1 year, it's because we didn't detect the disease. They probably have died. That died having the disease in the same duration. Because if 2 people got cancer, and then let's assume they had the cancer onset at the same time. I think let me go to the next slide where we will have more explanation of that. So this is an example of what happened. So this is a person, this first person, he or she develops cancer. The biological onset is 2000, the year 2000. Then because there was no screening, the symptoms started. The person went to hospital after a series of diagnoses. He diagnosed the cancer in 2008 and treated him. Then he died in 2010. So we assume that 2 years, he only survived for 2 years. But let's assume that, let's now look at it. In the second example, this person also had the cancer onset at the same biologic time. But was very lucky because in his city there was a screening program. He attended a screening program, and in 2005, he was diagnosed with the cancer and was treated. But in 2010, he died. So we assume they lived longer than the other ones. But if you look at them, the onset is the same for everyone. Just that the detection occurred earlier for the last, for the second patient. As for the first patient, the detection was detected too. So they all live with the cancer for how many years? 10 years. 10 years. So actually our screening did not improve anything. What our screening did was to subject somebody to unnecessary chemotherapy and then hospital attendance and cost as well. There will be the fear of living with cancer. So most people would have preferred to die. I know people that you tell them go and test for HIV, they say, I'll die in my ignorance. But that's not good because we know for sure that HIV, you get early treatment, you can survive. It's not like this kind of cancer. So, that's it. So it said sometimes it's desirable to examine survival in a group of patients who were diagnosed less than 5 years. So that is where the 5-year survival rate becomes a problem. Because if you now want to see the survival rate of a cancer patient who have just been diagnosed 5 years, you have to wait 5 years before you do that. So it becomes difficult if you want to use a 5 years test as a criterion. So in this situation, you have to use different kinds of measures, not necessarily 5 years. So another limitation of 5 years is that it does not show the experience of patients up to the 5-year point. If you follow so many people for 5 years, you might not be able to, at the end of the day, only see the 3 alive in this group. So let's say there are 2 kinds of treatment. I'm going to show you the example here and then we'll talk about it. So these are two groups, Group A and then Group B. Let's see. They receive treatment for colon cancer. Maybe one chemotherapy, the other one surgery. And then we start to measure them. At the end of 5 years, we have only about 10% of each of them alive. So the 5-year survival rate becomes 10% for each. However, let's look at these people. Group B. What do you think happened in Group B? On the graph, what do you think happened in Group B?
Most of them died within the first year.
Yeah. So death was very high for the Group B. You can see that most people, like within the first year, they had only about 30% alive. And then it continued to decline until the 4th year. But if you look at the Group A, see how the survival occurred. It was not until the 4th year that there was sharp increase in death. People survive. So when you use just the 5-year survival rate, we make this kind of information that in the course of 5 years, how was death occurring? Because I'll go for treatment. If these 2 treatments, I'll go for the first one at least. I can be sure I'll probably live to the 4th year before I go away, unless I wish to die early and go to heaven. So now they observe survival rate. So that's another approach that we use in measuring survival. And usually we use the life tables. And the life tables are very economical as well as efficient. So we will be talking about the life table. But what the life table is just a summarizing technique that we use to describe the pattern of mortality and survival in populations. So if you read Gordis, you will see how life tables are calculated. I think we have some examples here just before we shift. What time is it? Yeah, we can make it. So this is hypothetical example. So this is not actual data. Hypothetical study of treatment results in patients treated from 2004 to 2004, and then we follow them to 2005. We are assuming that nobody was lost to follow-up. I'm sure at this stage we know what lost to follow-up is. So nobody went missing. At least everybody was followed we had information about everyone. So if you see 2000, those people that started in 2000, we were able to follow them for the 5 years, at least. Follow them 2001 until 2005. Other people were treated in 2001, so we couldn't follow them in 2001. So that's the way until the last group joined in 2004. So this group, we only follow them for how many years? Just 1 year. So usually we have this kind of scenario. That is where we're talking about a 5-year survival rate. If we're using the 5-year survival, then the group 1 would have been okay because we can easily calculate. But this group, we have to wait until 5 years because we need to know something. We need to take decision about our treatment if it is not good. So we have a way of calculating for the life tables, the survivor. So here we have arranged the data a little bit to look nice. So we can say that first year instead of using the date. So in the first year, this number of people were at risk. Like the start, when we observe them for the first year, these people survive in this group, survive here. Because this group, only 43 survived, but we didn't observe them again, so you don't see anything there. That's what happened in the future. Okay, so we can add. This thing is really creating something. It's better. Hide it. It's better to hide it there. So now here, we look at probability of surviving for the first year. How do we get that? We have the total number of people who survived in the first year, and then we have total number of people who started. So the total number of people we have observed for 1 year as the denominator, and the number of people who survived. So we have that one as 0.525. Then here we can do so for the second year. Can do the same. So when we do that for every year, we can do the calculation. I hope everybody is with me on that at this stage, and you understand how we are calculating for each year. Does anybody have a question with this? So that's excellent. I think we're almost done with the course. So here, this is what we can do. So for the first year, people that we observe, how many survived? Second year, third year, fourth year, and fifth year. So we have everything there. Now, what is the probability of you surviving for the 5 years? So we find what we call the cumulative probability, which actually uses the information over the course of years. So the cumulative probability, at least we know that when we are calculating cumulative probability, it's just to multiply. So we multiply all the probabilities for the first year, by the second year, third year, fourth year, and the fifth year. Then we got the probability of surviving after you've been treated with cancer. And you've been treated is about 9%. So we can have also a survival curve like this, which shows how people, so at least when we did, you can know that, oh, and this is my probability of surviving for the first year, for the second year, for the third year, for the fifth year. That's it. Now, we also have to deal with issues like loss to follow up, because And I think we will take break, but not after this slide. So we have to deal with issues like loss of follow-up. There's not everybody that will even keep appointment at a hospital. People forget, people travel for holidays, and then people relocate. So even if we have a very good steady way of following people, and then they get employment as a World Bank director, they have to move. It's difficult for you to tell them, oh, I just need to follow you and see what happens to you, so don't go. And they might not even tell you. You go to the home and you call the address and the person is no longer there. So there are issues of loss to follow-up or the withdrawals or people who call it has been censored. So this loss to follow-up happens because subjects cannot be found or they decline to continue participating in a study. They get tired, so they won't become. So when we want to calculate the survivor, and we want to look at those at start of the interview, the death and the loss to follow-up, we have to consider all this because we just want to. We cannot just ignore those who died, those who got lost to follow-up, and all those. We have to count everyone. Let's take a 10-minute break because this is our second break. At least we had a break after 2:40. When we come back, we can quickly actually finish whatever we are doing. So 10 minutes, please. Okay, so welcome back. So, we are still talking about the live tables. I have some few questions about why some measures were subtracted. Like, let me go back to that table. So, if you see when you are calculating for the second year, you see that the denominator takes away 43. This is because these 43 people here were not followed beyond 1 year. So we cannot keep them as part of the denominator. Yeah. So here we had 197 people alive. But these 43, they were treated in the, I think, in the 4th year, followed for only 1 year. So in the second year, we don't have any information about them. So that's why we have to take them from the denominator. We assume that they have been censored. In actual listing, we say that they've been censored. So it's the same for the next calculations where like you come to this one, you have to take 16 from the 71 because they've been censored, they were not followed the following year. It's the same thing that you do until you get to the last one. So that is why we subtracted that one. Find a way of hiding that one. Okay, so we got here. So with the live table, there's some information we have to know. When we want to calculate survivor, so those are alive at the time of interval, we get deaths and then loss to follow us, they have to be considered in the live table. Now, so the number of people who are effectively at risk of dying during each interval are those at the start of the interval. And then we usually make adjustments for those who are lost to follow up. So we see that at the interval, how many people were, at risk at the start of the interval. I think when we get to so the loss to follow-up, one assumption we make is that we believe that loss to follow-up occurred uniformly. Sometimes loss to follow-up may not. Probably somebody was lost to follow-up after the first week. Another person just before we measured. So, but we believe that it occurred uniformly during the entire interval. And that those lost to follow-up were on average at risk for the half of the time, half of the interval. So those are assumptions we make. That's what it occurred, and then they were only at risk for half of the interval. So if the interval was 1 year, then we assume they were at risk at 6 months. So when we want to calculate the number of people at risk during the interval, we subtract half the withdrawals during the interval from the start. So people that started, like 200 people started, if 20 people at the end of the day have been lost to follow-up, if we want to get our denominator, we will just have 190 because 20 people that were lost to follow-up, we take half because we assume that they were at half risk, so we just take half of them and add to the. So we subtract the loss to follow-up, and then we just divide the loss and add half to those that were at risk and those who are still in the study. So this is a typical example of life table, and we will go through this one a bit slowly. So here, these are symbols. We have the first year, so the number of people are alive at the beginning, the number who died during the interval, so the number who withdrew or lost to follow-up. So effective number exposed or at risk of dying, we'll talk about that. Then the proportion who died during the interval, then the proportion who did not die or who survived. And then we call it something cumulative survivor. So who have survived from the enrollment of the study up to now. Here, we had 350 people, 375 people starting the first year, or 375 people who have been observed in the first year. People that died, 178 people died. Nobody was lost to follow-up, so withdrawal was 0. So those who were at risk, because nobody was lost to follow-up, then the exact number that started were the numbers that were at risk. Now when we do the proportion, this is actually this divided by this to give us the probability of dying during the interval. Then, if we subtract this from 1, we get the probability of this surviving. However, we can even, if we want to go the long way, we can take this one from the number who were alive and divide whatever we get by the total, so that we get the proportion who survived. Then, we try to get the survivor, the cumulative survivor. And in the first column, the cumulative survivor is actually the number who survived because there's no, the study has just done for the first observation period. So when we come to the second observation period, which is the second year, now when we subtract, we had only 197 who were at risk or who were starting the second year. Then we know that 83 people died. We had lost to follow-up of 43 people. So those who were effectively at risk is we divide the 43 by 2. Or we divide the 43 by 2 and subtract the results from this one. So when we divide 43 by 2, we get 21.5, isn't it? I hope I did well. 21.5, yeah. So we subtract 25.5 from this. That gives us 175.5. Then our proportion who died, 83 divided by this one, effectively at risk. We are not using this one because of loss to follow-up. So we cannot use this one as a denominator because we believe that we know that 43 were lost to follow-up. And we assume that these 43 were observed only for half of the period. So that is why we divided this by 2 and subtracted from the number. So for the half of the period, we didn't observe the 43. So we get this one. Then we need to know proportion who were alive. And that usually, you can just subtract 83 from that. You get everything. You subtract you take into consideration the loss to follow up and then divide by this. Or you can subtract this one from 1 because those survived plus those who died will give that 1. Then we need cumulative survival. So what is the probability that person will survive at the end of the second year? That's the cumulative survival. And that, in simple terms, is this one times this. So this probability of surviving times the cumulative probability of surviving for the first year will give you this one. It's the same thing when we come here. Let me use the last one. So the last one, we had 16 people starting the interval. 2 people died, 6 people were lost to follow-up. So effectively at risk is 13 because 6 divided by 2 is 3 minus 6 and 16 minus 3 gives us 13. Then when we divide our 2 by 13, we get this. When we subtract 1.54 from 1, we get, when we subtract 0.154 from 1, we get 0.846. And then, so that is the probability of surviving at this interval. When we multiply that one by this, we get this. So at the end of the day, when I ask the question, what's the probability that a person survives up to the 4th year? What would be the answer? What is the probability that, so 375 people were treated for cancer and they were followed for 5 years. What's the probability that a person survived for them at the end of the 3rd year, at the end of the 3rd year?
0.193.
Yes, so we use the cumulative survival. 0.193. These are likely questions that you get. So understanding this one is very important. So we can ask what's the probability of surviving up to the 5th year, and that is this.
Would we say like 19%?
Yeah, we can say 19%.
Yeah. Okay.
Yeah. So you can say, probability you can reduce it to percentage or you can just say that. So 19%. Usually the 19% is more acceptable because people are very uncomfortable. Even me, I'm uncomfortable with 0 point something.
Right. Yeah.
Yeah. So that's very important. Thanks. Any question on that? Yes.
This is more of a semantic type question, but if you ask what is the probability of someone surviving up to the 4th year, do you count at the end of the 3rd year or end of the 4th year with the table?
So what's the probability of surviving up to the 4th year?
Mm-hmm.
I think I will do the 3rd year.
Okay.
Because up to it's not at the end of the 4th year.
Okay.
I think I've seen a question like that. I don't know. I think I came across a question like that. What's the probability of surviving up to the 4th year? And I use the 3rd year because usually at the end, what is at the 4th is the end of the 4th year. Any other question? Yeah.
With leak tables, there's still the problem of knowing like when exactly people were diagnosed, right? Like there's still error associated with like how far they are along when you like started treatment and whatnot, right? Like that's still a source of error with like?
Yeah, as I said, in every measurement, once you make assumptions, then there will be some error. So we've made assumption that people are lost to follow up uniformly, which might not be the case. So there's some kind of assumption. And what we are doing here is that we imagine people have been treated, and then we want to see what the probability they will survive up to this year. So that's what we are doing. Is the treatment necessary to see? As for death, nobody can stop it, but our aim is to lengthen the time it will take from a person to die. So is the treatment actually prolonging people's life? In some cases, prolonging the life may not be necessary, because if prolonging the life a person is living in pain or living in, it may not be necessary. That's a very controversial issue. But our intention is to delay death and not to stop death, because death we cannot stop it. It will occur when it will occur. So that's another approach, which is like the life table, but which is the Kaplan-Meier. And it's for that one, in contrast to the life table, the Kaplan-Meier method does not use predetermined intervals. So like attention is whenever death occurs, there's some kind of calculation. So that's one thing about the Kaplan-Meier. So the probability of death is calculated at the exact point in time when each death occurs. So with the life table, we assume that the death occurred within an interval of 1 year. It could have occurred maybe in the first month. This is the point, the first month of the year. And then, but in Kaplan-Meier, if it occurs in the first month, we know the probability of dying at the exact time. So the number of persons who died at that point is the numerator, and the number alive up to that point is the denominator. So let's see if we have so there's a figure for us to see. And then in that figure, we have people that have been observed for 24 months of this time. And then we have 4 patients. So we have deaths occurring at the 4th month, the 10th month, the 14th month, and the 24th month after enrollment in the study. So the first patient died in the 4th month, and we calculated probability of dying at the 4th month as 1/6, because no one was lost to follow up by then. So that is the Kaplan-Meier. We calculate the probability. So here is the Kaplan-Meier table. So you can see 6 people started the study. So at the end of the 4th month, 1 person died. So the probability will be calculated. Now we decide to follow them. After the 10th month, 1 person died, but obviously 1 person was lost to follow up. So because 1 person died earlier on, and another person has been lost to follow up, what would be the denominator for the 10th? The 10th is 4. The denominator is 4, so it's 1/4. Then on the 14th month, 1 person died on the 4th, so we are left with 3, and 1 died, so it's 1/3. Then we follow them. 1 person lost to follow up. So at the end of the 24th month, 1 person died, and it was only 1 person at risk. So 100% of the participants died. So this is the Kaplan-Meier table when we do the table. So the 4th month, the calculation is there. The way to find the cumulative probability is the same. Cumulative probability of survival. So here, and then we have probability of surviving. The cumulative probability is this. Here we have 4 people. See, the Kaplan-Meier did not count those who were lost to follow up. So as part of the denominator. So 4 people were at risk, 1 died, and then the probability of dying is this, probability of surviving, the cumulative probability. So this is what we do. Here, at the last month, the 24th month, the cumulative probability of surviving is what? 0. Why? Because everybody is dead. So if I ask questions, what's the probability of surviving up to the 24th month, we say nobody survived. The Kaplan-Meier, I think it's very easy to do. So that is just showing you how to do the cumulative probability and other things. Okay, so all these are just the calculations of how to do it, which I've spoken about. So this is because of computer programming. When we saw that, you can have a very nice chart or diagram like this to show how deaths were occurring using the Kaplan-Meier. So why is it very important? When we have the exact death, the time that the exact death occurs, then it makes use of all the time of the information. So the Kaplan-Meier becomes very good to use. So, but one, the Kaplan, we are just calculating every death. So we have a very large sample size. It becomes difficult. But this was the case in the past. Today we use a computer program to produce the curves and everything for you, which makes it easy. So it can be done. You don't have to stress yourself calculating by hand. So there are two important assumptions in life tables. So in life tables, the assumptions are that there has not been any secular change in the effectiveness of treatment or in survival over the calendar time. So in other words, if there has been treatment change because people are joining or getting treated, then as you follow people, it will be biased. So if study takes many years, then this assumption may not be valid because therapies may improve. And so one way to evaluate this concern is to analyze the group differently. Or you have to analyze them separately. If you are following people who are receiving treatment for over several years, because the kind of diagnostics will change, the treatment will change, it will affect your results. So the second assumption is about the follow-up of persons enrolled in the study. So in most studies, the actual reasons for loss to follow up are not known. You might not have any idea. Because we are following a large number of people will withdraw. So it creates, when there's loss to follow up, there's a program. I don't know if you have done it. Because people are going out might be different from those who remain in the study. People will be lost to follow up because their disease have become, and if you live in maybe some countries where there are issues, when somebody is seriously sick in the city where you can get some treatment and you feel like nothing can be done, they just carry you to the bridge. Maybe manage you by themselves or wait until death occurs. So when you don't have such information about these people, all you know is really sick who are about to die may be taken away. And so your estimate will be biased. That's one thing. It is important to know, in almost all studies, to know whether people who have left the study are different, significantly different from those who remain. And you try to take measures to reduce that occurrence. So we have to know that life tables are not just for calculating death and survival. They can be used for other outcomes. Earlier on, as we said, we can be used for the time to which somebody develops a disease, or the time to which there's a relapse after a condition has been treated. So we can use the survival curves to also compare groups. So for example, those who are treated and those who are not treated. I think we showed one in our earlier slides where we saw group A versus group B. One measure is about median survival time. What do you think the median survival time is?
The time of the 50% of the participants survive, or you could
So it's the time that 50% of the people are alive. Okay, or have died, at least 50% in any way. But what are the issues with the use of the median survival time? The same as the issues with the use of median. So what are the issues? Outliers. What have they done?
Outliers can drastically change the median.
So, that's the mean, isn't it?
Make use of only not all the samples of the observations.
Okay, so the median does not use all the samples of the observation because, yeah. But however, we also thought about how the median is very important, isn't it? Like, what can affect, at what point does the median become very important? We know that you use all the data, but when the data is also skewed or not normally distributed, median becomes very important. But here, the median may be a very good measure. So it says, now the median survival time is the length of time that half of the study population survives. And then it has two major advantages. So one is that the mean may be affected by extreme values. So the median, the extreme people dying too early and those dying too late may not be affected. And then if we have time, or if you don't have time, at least we can calculate it before everybody dies. You don't have to follow all the groups to know what time each of them dies, because to calculate the mean of deaths, that's what you have to do. You have to finish the study. But with the median, you're able to determine, because you are following them as soon as one person, if my interest is in the median, as soon as the half of the patient survives, I can terminate my study and then report. That's okay. The median survival time is 7 years or 10 years. Then another term is the relative survivor. So the relative survivor actually talks about the observed survival rate divided by the survivor as is expected. And we will talk this. We will just try to explain it. So the observed survivor, a 5-year survivor in a group of young people with colon cancer, if we want to compare it to observed survivor rate for young people without colon cancer, then, of course, young people without colon cancer, their survival rate within 5 years is actually expected, reasonably expected to be about 100%. So it is somehow easy to compare that one. And if we do so for maybe old people, or we just estimate survival rate of cancer treatment in people who are 100 years or 90 years, we computing risk for that time, probability of dying within 5 years, even without cancer, is higher. So we say in much older people, we don't expect the survival time, even when there's no cancer, to be 100%. So when we use the relative, we adjust for these kind of differences in life expectancy or the expectation, the expected death over the period. So that is the formula. So you observe survival in people with the disease, then about the expected survival in those with absence times 100. So here, this table gives an example. Let's see age group. So people who are less than 50 years, the observed survival rate is 60.4, and their relative survival, that's when you divide the observed by the rating, 61.5. Now, when we look at people who are 70 years, or even when we look down, you could see that the relative survival somehow increases. And then when you get to those who are 75, you could see the difference. There's a large difference between the observed survival rate and then relative survival. So here, obviously, there's not much difference between the observed survival and the relative survival. So that's the hypothetical example. So here, when we assume that the survival is 100%, and then the expected survival is this line, and then this is relative survival, and then this is the observed survival in the group. So today, we have discussed about Case-Fatality Rate. We've spoken about 5-year survival. We talk about observed survival rate. We've looked at the life table, the Kaplan-Meier, and then we consider the median survival, which we say is good because we can obtain that one. We don't have to follow the whole group. Now, is there any question? Yes.
What is relative survival for? Like, what does it show? I mean, it shows the number. I understand the equation, but like, what is it used for?
Okay, so if you look at the difference, it's for you to adjust for the age, because when you see when survival as we said, survival rate in young people treated with cancer, and then survival rate in older people treated with cancer. Of course, because of competing risk, you might be thinking that the survival rate in the older people is low because a lot of people might die. And then you might be thinking the survival rate in the younger people is high. So how do we do that? So we use the adjustment for it. Okay. So if you saw the example we gave, like in the younger people, there seems to be no, because the observed and the relative are somehow the same. Okay. But in the older people, you could see that there's some kind of difference when we did that adjustment. You see the point?
Yeah.
Yeah. So that's why we need to take into consideration your expected death if nothing happens to you.
Do they use like the life expectancy for the denominator? Like, what's the number?
That I'm not too sure, but I think they will have a way, because I don't know, have you done direct and indirect adjustments? Oh, okay, you've not done it. But when you get that, we can have a way of calculating expected mortality.
Okay.
And we can use, if it's a very large population-wide study, we can use the statistics based on the life expectancy to say that this is what we expect people at this age to die or not to die. Okay. So we can use the life expectancy, or we can, based on their statistics, calculate what is expected of a person at that age to die or not to die. So now, let me see, what time is it? And I think we have some few times to discuss about our paper. How many of us were able to read the paper? I know it was somehow challenging to read, especially to keep up with the methodology section. But we will not discuss too much about the methodology. But what were they trying to study in the paper? What were they trying to find in the paper?
How well it's affected.
How they
I don't remember.
lung cancer, okay. So how many of us were able to read? Oh, okay. I'll tell Dr. Kozinetz to set an exams on that.
We're kidding, we all read.
Okay, so you see, that paper is a very strong paper. If you look at the journal in which they even publish the paper, it's a very interesting paper. It has a lot of information on what we just discussed. If you have not read it, you can take time to read it. The methodology may somehow be slightly difficult to understand because they had to do so many things in order to avoid or to reduce errors. But in effect, they were trying to look at survival of people with first stage lung cancer. So they screen people, but which category of people did they screen?
Stage 1?
Yeah, but before you have to find stage 1, sir. But how did they? Because if you want to screen people for lung cancer, what would be your selection criteria? What? Smoking? Okay. And what again?
Age.
Older individuals.
Yeah, so why would you use smoking? Okay. And then why would you use older people?
Because it probably would have taken the lung cancer a while to kind of get in their lungs to develop, and so it'll be more evident in older people than in younger people who haven't smoked as long.
Okay. Yeah, and then so what were they doing? Because you want to screen. So one thing that we want to learn from this is that in screening we try to, in order not to waste resources, try to see people that are likely to have the disease. Because if you ever go for maybe people that are around 30, 40 non-smoking individuals and you're looking for first stage lung cancer, it may be an exercise in futility because you may not find any lung cancer case. So they used some kind of selection criteria. They were looking for people who they believe were at risk of having lung cancer, smokers, and then those who are somehow old. And then they used a lot of methods to detect lung cancer at the first stage. So there was some kind of baseline. If you look at page 1765, which would be like the page 3, the third page, you will see how they did the selection. They tried to follow people, and they finally diagnosed people with lung cancer. Now, when they diagnose people with lung cancer, they follow them for how many years? 10 years. Okay. So the 10 years, let's look at the results in, let me see, I have to see the page. Page 1767. If you look at the table, it gives information about the number of people screened. And they have a term called the median pack year. They have pack year. What do you think that is, pack year? The number of what? Cigarette smoke. So that's a very good, that's true. So there's a technical way of calculating that. And they have a way of calculating how many packs of cigarettes you have smoked per year. So they said if you tell us how many cigarettes that you smoke averagely, if you say 15, then we know that a pack contains 20, isn't it? So that's 15, and you smoke every day, and you have smoked for 20 years. Then 15 divided by 20 times 20 years that you have smoked. So give us pack smoked per year. So we find the average pack smoked per year for each person. And then they look at the lung cancer diagnosis. Then they plotted, what can we say about the table, the survival curve on page 1768. What kind of survival curve is that? based on what we have studied today? Okay, Kaplan, what can we say about the survival curve? Yeah. I've been doing the talking, so now time for us to talk. What can we say about the survival curve?
Stage 1, lung cancer has better survival rates than all other cancers.
Good, that's good, but there's something missing. It's a very good statement.
Within 1 month of diagnosis. Yeah.
What? So they put all lung cancer cases together. They were targeting stage 1. So all the lung cancer cases they have stage 1. But the treatments were some kind of different. So those who went through that resected clinical stage 1 lung cancer, you can see their survival rate. And so at the end of the 10th year, what is the survival rate for the resected clinical stage 1 lung cancer? That's 92. And you know what is associated? The 95 confidence interval. Have you done that in biostatistics?
We're about to.
Okay. Oh, not yet. Oh, okay, sorry. Just leaving. So that is a typical application of what we have learned today. We try to follow cases for 10 years. They did a screening. So if you look at their discussion, the substance of their discussion was that the argument that they argued, under the discussion, look at the last paragraph. They said, are these results sufficiently effective to justify screening people who are at risk of lung cancer? So they said, as compared with mammographic screening of breast cancer, for lung cancer, the rate of detection among the participants in this study who were 40 years of age and older were 1.3% on the baseline, and then 0.3% on screening, like annual screening. So the values were slightly higher than those for detection of breast cancer. So breast cancer detection was about 0.6 to 1.0% on the baseline, and similar to those for annual screening in terms of breast cancer among women 40 years and above. So what was the argument? The argument is that if we are screening regularly for breast cancer, then it will be important because we want to see how efficient is the screening, how effective it is to detect. And if it's detected, is there any treatment, good treatment for it? And if people get treated, is their survival improved? So that's the question that we're asking. So they actually try to solve. And that is what the argument says. So if you go on reading, in the next page, they were talking about how much it will cost. So they said the cost of low dose, that is CT scan, is below $200. And surgery for stage 1 lung cancer is less than half of the cost of the other stage. So the argument is that if we are able to detect people, we treat them early, and it improves life, and the cost is affordable, and the cost of surgery is also okay. And then they also mentioned that even the surgery does not pose a lot of risk. Because they said people that died from surgery was about 0.5% or so. So that's a typical way of using what we have learned here to make a case for maybe screening or for certain kind of treatment to be given to patients. So if you have time, please, you can read it and then for your own consumption, and if you have questions, you can ask. So with that, I just want to know if there's any other questions.
How come they're not screening?
What?
How come they're not screening then? Are they?
They are.
They are screening now. Okay, good.
But like sometimes insurance will cover it, sometimes it won't, but the U.S. Preventive Task Force, they just like approved for low dose viral CTs to be screened on. It's adults who have like 30 plus PEG years and then a certain age, like 50 years or 55 years old, they can start screening.
Okay. So when did they start that?
That was recent. Mountain State, they met last year to start discussing like how to go through insurance about it, but they started screening last year.
So because, you see, maybe this evidence, probably, because this one was done in several countries. You have US, you have Japan, and it's a very strong study. Even the journal publishing has very high impact factor, about 55 now. So if you are able to present a case like this, then you can be sure of influencing policy. That is a very good way, an example of how we use whatever we have taken in. Any other question? So if there's no question, then have a nice week and then see Dr. Kozinetz next week. And thank you for coming.
Thank you.